All right, so the heart. Now, the heart is, of course, going to be the pump that is going to push everything through our cardiovascular system. So last time we talked about blood. So blood is, of course, the liquid. What type of tissue? What's the connective? Right. So the blood is the mostly liquid connective tissue that is going to move things like oxygen, nutrients, electrolytes, all of those things through our system. Now, we, of course, have to provide power to move it through, and that power, of course, comes from the heart. All right, so the role of the heart is nothing more, nothing less than to make blood travel through our cardiovascular system, okay? It is a pump. It pushes things, it pushes with pressure on the blood so that that blood is forced through our vessels, okay? That's it. Nothing more, nothing less. This is actually not that complicated. A lot of people like to talk about the heart as though it's this like crazy complicated thing, that the cardiac cycle is crazy complicated. It's not, okay? Now, if we are going to push all of this blood through the system, what do you think we are going to need? We need energy, okay? So that means we also have to make sure that some of that blood is going back into the heart. So we're gonna have some vasculature for the heart. All right, what else do we need? So what is that energy going to do? What's it going to power? What type of tissue do you think that we're going to need in order to push all this stuff through? Does it just happen on its own? We give it some energy and it goes? So is it like nervous tissue? Is it connective? Is it muscle? Is it epithelial? It's muscle, okay? So we're going to need a crap ton of muscle, okay? Now, what else are we going to need attached to that muscle? So we've already said that we're going to need blood flow going to it, but we also have to have sources of input and output, right? We have to have hoses coming in, bringing blood to the heart, and then we have to also have hoses leaving the heart, right? So what are some of the places that we need this blood to go? Well, define everywhere. All right, so it needs to go to your body, right? So it needs to go to arms, legs, tissues, all those kinds of things. We're going to call that systemic. Okay, so it needs to go out to the body's systems. Where else does it need to go? Organs. Okay, that also fits with that. We're missing one thing in particular though. Because what kind of blood do we want to send to those organs? Yes. We need to send oxygenated blood to all of those tissues, right? And then return deoxygenated blood back to the heart. But we also have to have a hose coming out where we can take blood to the lungs so that we can get oxygen into the blood. So we're going to have at least 2 outputs from the heart. We're going to have at least 2 outputs from the heart. One going to the lungs so that we can oxygenate the blood, and then another one going to all the tissues, okay? So let's go ahead and look at some of those vessels, or look at the heart here in just a second, okay? Now remember that we have different types of blood vessels in our body. Remember that we have arteries that carry blood which direction? Away from the heart. So arteries carry blood away from the heart. Veins carry blood to the heart, okay? Where is the site for nutrient exchange? What do we call those? What type of blood vessel provides the site of exchange? Capillaries. Now, when we look at the capillaries here, see that we have this big network going through all of our tissues. What does that big network where we have all these little splits and branches and splits and branches and splits and branches, what does that allow us to get? More what? Keeping in mind that capillaries are really, really thin. Surface area. It's always a theme, right? We see it all the time. We need a lot of surface area, so we split it up into a bunch of pieces. That's where we're going to get the surface area. Now, something else happens here at our capillaries. Last time we showed you the pictures of the red blood cells, how they're those kind of biconcave discs and they stack up like quarters in capillaries. This is also where the blood is going to slow down, okay? As the blood moves from big blood vessels, like say your aorta, out into like your arteries and things like that, and then finally into arterioles, as they move into smaller hoses, they tend to it slows them down, okay? But because there's less blood flowing through them, we actually tend to get a decrease in pressure as we move through those tubes until eventually they stack up and basically come to a halt in the capillaries. They don't stop moving entirely, but they do slow down a lot, okay? So this is where your pressure is going to drop. Arteries will be dealing with massive amounts of pressure, capillaries will not, okay? Now, your heart is going to have two sides to help deal with these two things. So I said that we're gonna have two outputs, right? We're gonna have to push blood to the lungs, and we're gonna have to push blood through those arteries and vessels that we saw in the previous picture. So notice that we have one little circle here in our lungs, and then we have another circuit out here that's going to the rest of our tissues. So this is our systemic circuit, and then this would be our respiratory circuit, okay? Now, the two sides of the heart are going to push their blood in two different directions, okay? Or into those two different places. The right side of the heart, so this is your patient's right side, or from the perspective of the subject, not yours. If you're looking at someone's front, that means what is on your right will likely be on their left, okay? So when I say this, I mean the right side of the heart. So the patient's right side of the heart. This is going to take in all of that blood from all of those systems, okay? And it is going to push that blood out. Where's my cursor? It's going to push that blood out to the lungs, okay? So the right side pushes deoxygenated blood to the lungs. The right side of the heart pushes what kind of blood? Deoxygenated blood, and it pushes it where? To the lungs, okay? So what type of blood do you think the left side of the heart is going to deal with? Oxygenated blood. Where do you think we're getting that oxygenated blood? From the lungs. So that means this blood is going to then get pushed out through the aorta and go to the body, okay? So right side of the heart pushes deoxygenated blood to the lungs. Left side of the heart pushes oxygenated blood to the tissues. Does that make sense? All right, easy peasy so far. Now, we are going to be dealing with a system of what we are going to call the great vessels. Now, the great vessels are great because they are large, and they're also going to be fairly important, and this is kind of where they are inputs and outputs from the heart, okay? That's probably the easiest way to think about what the great vessels are. These are inputs and outputs directly from the heart, okay? Now, we have a couple here. We have the superior and inferior vena cava. Let me make this a little bigger just for purposes of this. For studying, this picture is great like that, but for talking about it, it's easier to do this. Hopefully the internet people can still see. Yep, okay, good. All right, so these are the great vessels. So inputs to the heart are going to be these large veins or the vena cava. Okay, we have one coming from the top, so it's going to be the superior vena cava, and we have one coming from the bottom, which is going to then be the what? Inferior, okay? So these are going to feed into this portion of the heart. So this is called the right atrium, okay? So we are dealing with deoxygenated blood. So the color coding on the blood vessels here is telling you the general oxygen content. If it's showing it to you in blue, this means that we have a really low oxygen content, okay? Red, that means we're dealing with oxygenated blood, okay? Now, when I say deoxygenated, does that mean there is absolutely no oxygen left in this blood? No, okay? Remember that we have to maintain some level of oxygen in these. We can't get it all out. We're not that efficient, okay? So these are going to drain into the right atrium, which then will go out and push through the right-hand side of the heart and go up then to the lungs. Now we're gonna go up through what's called the pulmonary trunk. Now the easiest way to remember this one is that this one looks kind of like a T, okay? So the pulmonary trunk is the base of our T, okay? Now, once it splits and we have left and right sides, we're going to call these pulmonary. Are these going away or towards the heart? Away, so these would be pulmonary what's? Veins. Veins? Arteries. So these are the right and left pulmonary arteries, okay? So pulmonary trunk into right and left pulmonary arteries. Now, We then go through the lungs. In the lungs, this is where we are going to pass through those capillaries where they get oxygenated. We're going to pull them back into our heart. So we're going to pull them back to the heart using our pulmonary veins. Notice that they are red. They are red because these now have oxygen in them, right? So they can then come into which side of the heart, left or right? Left, right? And then we can push them back out and they'll go out through our aorta right here, okay? So those are the great vessels, the superior and inferior vena cava, pulmonary arteries, pulmonary veins, and the aorta, okay? Now, they're then, as we are moving them through the chambers of the heart, they are going to pass through some valves. Now, the valves that separate the right and left atria, and so separate the atria from the ventricles, so they are at the space between the right atrium and the right ventricle and the left atrium and the left ventricle. These we are going to call atrioventricular valves, okay? So atrioventricular, so this tells you that they are between the atrium and the ventricles. I don't know why this PowerPoint just skipped naming the chambers of the heart. Seems like an odd decision. Anyway, all right, so we're gonna go from the atria to the ventricles. So the split in between them is gonna be these AV valves. Now, these valves are gonna be very important because what these valves are going to do is they are going to prevent backflow. Whenever the ventricles contract and we're trying to push that blood to the heart or we're trying to push it up into the lungs, we don't want it fighting against itself. We don't ever want to push blood backwards in the system because that's a waste of energy, okay? So we don't want to do that. Instead, we use these valves to basically act as doors that we can close. Now, these doors are going to only be open so that they can let blood into the ventricles. Whenever the ventricles start to push against that blood, well, this is fluid. You push on fluid and it's going to create some pressure, okay? And what that pressure is going to do is it's basically going to hit the walls of those valves and it's going to push those walls closed. Just like if you wanted to close this door, you have to put pressure on the side of the door, right? So these, whenever the ventricles try and contract a little bit, it's going to push against the sides of those doors and it's going to cause those vessels to shut, okay? Or cause those valves to close because the valves are open or are made in such a way that they open to let blood in, but then some back pressure essentially causes them to push back, okay? Now, this happens so it stops backflow of the blood so that we can only have one directional flow. So these are going to be very important. Now, you may have heard these called either the bicuspid or the tricuspid valves in the past. Now, you can see where these little valves are connected to these chordae tendineae here, okay? So these are connected to little pieces of connective tissue that push down against some muscular structures on the walls of the ventricles. This one has 1, 2, 3, so this would be called the tricuspid valve. So when I was talking about these doors, right, the tricuspid basically has 3 little flaps, so 3 cusps, thus it would be the tricuspid valve where each of those little cusps has a little spot right here. This one only has 2, so this is our bicuspid valve, okay? I'm not worried about that, though. You can just call it the left AV valve and the right AV valve. That is perfectly fine with me, okay? Or atrioventricular valve, I'll put it that way. All right. Now, if someone were to say have strep throat and you have a strep throat infection for too long and you let it go untreated for a very long period of time, sometimes that strep infection can move, okay? One of the places that it will move is actually going to be down here into your heart. So we can transfer some of those bacteria, and if they happen to move through the blood, they can actually find their way to these little cords in your heart and take up residence. And if they stay there for years uninhibited, they'll actually cut these little cords or make these weak, where eventually one of these will break, which means the valve itself can't be opened correctly or closed correctly, because now it's just kind of flapping. So now you're actually letting in a bunch of backflow and stuff like that, and you can have major heart problems due to something like that. So that's actually one of the reasons it's very important to treat something like strep throat, is so that our valves work correctly. Now, that takes a very long time. Like it could be from an infection that you got when you were in your 20s or something like that, and you wouldn't know it until you were 55 or 60, and then you basically have a heart attack. Now, we also have valves here separating our ventricles from our great vessels. So in this case, this is our pulmonary trunk. Okay, so this would be the pulmonary semilunar valve. This one is going up to the aorta, so this would be our aortic semilunar valve. They're called semilunar because they look like little half circles, right? Or like little half moons, okay? Now, these valves are gonna work the same way. Notice that if we were to kind of push right here, that you can see where it'd be easy to push blood flow through it this way. But once again, blood, as it's trying to come back down, is gonna hit these little things and it causes the valves to shut, okay? All right. Now, the heart itself is positioned in a very particular place in kind of your thoracic cavity or in your torso. Remember that we call this region the mediastinum, okay? Now, it's going to be positioned in between your lungs to the point where we actually have some little divots in our lungs to help make room for the heart. But notice that we have the primary portion of the heart and all of the great vessels positioned right behind your sternum. So your heart, the bulk of your heart is actually slightly to the left of this. So the sternum really protects this kind of right atrium and portion of the right ventricle region, okay? But then is exposed over here kind of on the left-hand side in between ribs 1, 2, 3, 4, and 5. Okay, so the base of the heart is actually going to be around rib pair number 5. So this would be called the base of the heart. This would be called the apex or the point of the heart. Notice that this is off center just a little bit. Now, this also tells us that whenever we're looking at the left lung, we're actually going to see a big notch in the left lung for our heart. We're going to actually call that the cardiac notch. So this is, like I said, where our heart is positioned. We can see it right here in between the lungs as well. Now, because this is a tissue, we also have to have epithelial tissues coating it and protecting it. Now we're going to call this, in this case, we're going to call this the pericardium. Okay, so the pericardium is going to be the system of membranes that's going to cover and protect the heart. Now, the fibrous pericardium and the parietal layer are going to form what's called the pericardial sac. So it's basically going to be a little bag that your heart is going to live inside. Okay, so it's going to create a little cavity inside where the heart is going to be found. Okay. Then we're going to have a visceral layer, which we're going to call the epicardium. So remember, we have parietal and visceral layers to all of our serous membranes. Okay, the visceral layer is going to be the one that's actually touching the surface of the heart. So this is where we're going to actually have a little bit of fluid on the inside. Okay, so that's our system of membranes. All right, so now we can actually look at some anatomy here. Now, we've already looked at our great vessels. So we call this region right here the aortic arch. This would be the ascending aorta, aortic arch, and then descending aorta right here because it's going down. Arch because it's kind of bending here. And we have 3 major vessels right here that we'll talk about next time. But as we're looking at the heart, once again, we have our apex here. Where you see the apex of the heart, you're going to see this big blood vessel reaching down kind of right in between. Okay, this blood vessel is called the interventricular artery, and it's on the front, so it's the anterior interventricular artery. Interventricular, so it tells us it's between the ventricles. So by looking for this blood vessel right here, this is what's actually going to tell us where our heart is positioned, where the split between the right ventricle and the left ventricle is going to be. It's basically going to be on either side of this blood vessel here. So the anterior interventricular artery and vein. Okay, now this then is our left ventricle and this is our right. So this tells us that not only is our heart kind of slightly to the left and kind of slightly laying down on its right hand side, it's also twisted a little bit where the left hand side of the heart is actually pushed more posterior. Okay, so it's actually got a little bit of a twist to it. So you mostly, when you're looking at the front of the heart here, you mostly see just the right hand side. So this would be our right atrium, this would be our right ventricle. Okay, now what's going to separate those are these little lines right here. These are your coronary arteries. So the red one is the artery right here, and it's going to live in this little gap called the coronary sulcus. Now, the top of the heart also has these 2 little hats. Okay, these 2 little connective tissue hats we're going to call auricles. Okay, A-U-R-I-C-L-E. So not oracle like the networking thing or oracle like the future tellers from various types of mythology. No, just oracle as in A-U-R-I-C-L-E. Okay. Now, once we move to the back of the heart, we now can see our left ventricle, and we can also see this huge blue blood vessel right here. So this is the coronary sinus, okay? The coronary sinus is basically going to be the large coronary vein. So a large vein on the back of your heart. So this was the one that's actually going to return all of the blood flow from your heart and return it into the right ventricle so that we can pump it back out. So we have like a little circuit of blood vessels going around the heart. We have a bunch of muscles, so we have to feed it with all that energy and stuff like that, okay? Here's our posterior interventricular artery and vein back here as well, okay? So once again, now we have our left ventricle, now we have our right. We can also see the pulmonary veins. And notice that we have 1, 2, 3, and 4 pulmonary veins, okay? So pulmonary veins carry oxygenated blood. That's why they're red. So this also tells you that this is going to be our left atrium. So left atrium and our right atrium here now, because we were looking at it kind of in the same direction that you and I are right now, okay? Now, we do have some other anatomy bits on the inside, but I want y'all to pay attention to the thickness of the walls. Now, the right ventricle pushes blood to where again? So the right side of the heart pushes blood to the right side of the heart pushes blood to the lungs. So because the right side of the heart pushes blood to the lungs, this tissue has to be pretty thin, or doesn't have to be really, really thick. We don't have a whole lot of pressure there. It's not going very far, okay? Just like you don't have to expend very much effort to say, like move from one of the, okay, one of these squares to the next. It doesn't take a whole lot of force to do that. Like if I wanted to jump to the next block, that doesn't actually require a lot of force. But if I wanted to jump from here over there, that's a lot more force, right? Which means I have to push out with a lot more force. So the right side of the heart, because it's only pushing to the lungs, because the lungs are very close, we have quite thin muscular walls to the right ventricle. The left ventricle, because it's pushing it everywhere, is massive, okay? Tons of muscle here so that we can generate a hell of a lot of pressure so that we can push things out to the body's tissues, okay? So lots of blood pressure is gonna be taken or pushed by that left ventricle. Now, we also need to realize that the wall of the heart is gonna have have a few layers. We have muscle here, but we have an outside, so we need something that is a covering, and we also need a lining. So that means we need our epithelial tissue. So the outside of the heart, so there's going to be the epicardium, epi meaning outside. It's composed of simple squamous epithelium, and then we're going to have some areolar connective tissue, as well as some adipose. Then we get into the myocardium. This is the actual muscle. What type of muscle do we find in the heart? Cardiac muscle. Okay, notice that we see these little branches. Now, the reason it being cardiac muscle is going to be important here. These little branches here and the way that the muscle cells can talk to one another and send signals down their entire length is one of the ways that we're going to make sure that the heart contracts the way we want it to. And then we have the innermost lining, which is the endocardium. So once again, simple squamous epithelium. So nice and thin, and it's attached to the muscle using areolar connective tissue. All right, so now let's go ahead and slice off the front of the heart so that we can look at it. So now what we're looking at then are the 4 chambers. So the top chambers, remember, are what? What do we call the top chambers? What's the word I used? Atrium. So the top chambers are atria. Okay, so we have the right atrium and the left atrium. Okay, these contract and push blood through their valves into corresponding ventricles. So here we have the right ventricle, which pushes its blood up here through the pulmonary trunk and into the lungs. And then here we have the left ventricle. Notice the thickness of the walls. Now, because of where this slice is taken, it looks like the left ventricle is smaller on the inside than the right. That is not true. The volume inside the right and left ventricles is the same. And it's actually very important that it stays the same. Okay, so when your heart contracts, we want to make sure that we are pushing the same amount of blood from the right side and the left side. Okay, so they call this isovolumic. Okay, so the same volume. Okay, for both the right and left sides. Let's make sure that we don't have swelling in places and stuff like that. So we don't lead to any swellings or edema due to like incomplete passage of the two things. Now, like I said, we have our tendinous cords. We have these little bulbs of muscle connected to those. So we're going to call these our papillary muscles, just kind of like we did in the eye. The space in between our ventricles, just like we had that space on the outside, we called that interventricular, right? In this case, just like in your nose, instead of it being your nasal septum, this is the interventricular septum. So it's the septum in between your ventricles. A really common birth defect is actually for someone to have an incomplete interventricular septum, or like where there will be like a little hole where it didn't completely fuse together. So sometimes the two ventricles, there can be some backflow. Pretty common. It usually goes away. But that's actually one of the most common birth defects in hearts, is actually a little bit of a ventricular septum. Oh crud, what's the word? Sinus, I think, something like that, where there is a little bit of a space there. They're not fused completely together. I think we've already named everything else. Oh, so I showed you the coronary sinus before. So the coronary sinus leads into this little guy right here. So this little opening. So after the blood has gone to the heart tissues and oxygenated all of those heart muscles and things like that, it gets routed back through the coronary veins and then finally into the coronary sulcus, and those will drain back into not the superior or inferior vena cava. They will actually drain directly back into the right atrium of the heart. And then we also have our fossa ovalis here, which is another little divot and opening in the right atrium. We talked about valves. So here we can see the kind of appearance of our two valves here. So right atrioventricular valve, notice that we have three little cusps. Left, we only have two, so that's why it's the bicuspid valve. Pulmonary and aortic semilunar valves here. So pulmonary and aortic, you can see those. So this is just if you're looking at the top. So we can see kind of what they look like when they're open or closed. That's more of kind of physiology stuff though. Now, once again, we do have blood vessels on the heart that we need to worry about. Now, as blood comes out of the heart, we're gonna have little branches off of our aorta right here. So this is where we're gonna get our oxygenated blood. So we're gonna have these first little branches off the aorta, and we're going to call these the coronary arteries. Okay, so the coronary arteries are going to carry oxygenated blood to the tissues of the heart. So we have the right side, which is going to, of course, feed the right side, and the left side, which is going to feed the left. So if we follow this right coronary artery down, we can see our posterior interventricular artery is going to be back here. We also can see this large one down the side here, so down the base. So we're going to call this the right marginal artery. Okay, so because it's wrapping around the base of the artery or base of the heart, we're going to call this the marginal artery. Marginal because it kind of looks like it's making up the margin of the front of the heart. Okay, the left side wraps around, so it's going to be the circumflex artery. Circumflex because it's wrapping around. And then we're going to have our anterior interventricular artery that I pointed out before. Okay, so left coronary artery splits into the circumflex because it wraps around, and then the interventricular artery or anterior interventricular artery. Those are the arteries that you'll need to know. So importantly here, coronary veins, basically it takes the blood from those and drains it back into the heart. So they're going to go back into the coronary sinus. Okay, so we have our middle cardiac veins, small cardiac veins leading into the middle cardiac veins, and then finally we have the great cardiac vein, which is going to be found parallel to that anterior interventricular artery, and then those will all drain back into the coronary sinus and then back into the right atrium. Okay, now the reason these blood vessels are important is because you have likely heard of someone having a heart attack. Okay, that's actually probably why a few of y'all are here. Okay. Heart attacks happen when there is an occlusion of the coronary artery, which means we cannot get blood flow to the heart. We can't get blood flow to the heart, which means your heart cannot beat the way it's supposed to be because now you have no oxygen going to that muscle that is beating a bunch. And usually when you're having a heart attack, it's likely because you are stressed and you have higher than normal oxygen requirements, which means your problem is even worse. Okay, now we tend to refer this pain down to our left arm because it's kind of in that dermatome. So we will refer some of that pain into the left arm, but usually when this happens, they will say their chest really hurts badly and they'll have pain in their left arm. That tells you that they may be having a heart attack. And this is oftentimes caused from coronary heart disease, or atherosclerosis. Okay, so we have a hardening of the blood vessels, or we have some plaque buildup on the insides of the vessel. So the vessels are narrow, and then eventually you get a sudden and complete occlusion of that coronary artery. It doesn't work, can't get blood flow to it. So the muscles are like, hey, I need oxygen, I need oxygen, I need oxygen now. However, so like if this happens to a muscle in your leg while you're running, you have a cramp and it hurts. Has anyone ever had a cramp in a muscle, like while they're exercising? Hurts like a bitch, doesn't it? This is in your heart. It happens worse and in your heart, which causes all the other downstream stuff as well. That is why that is such a big deal. So to go in and fix that, they will oftentimes go in and they will literally put in like little tiny plastic sleeves in to push open the blood vessels to make sure that they stay open. Or they'll actually route the blood in a different way that we might call a bypass. A stent. Yep. So a stent is when they insert the little plastic sleeve that pushes everything open to make sure the blood flow can continue moving through. A bypass is basically where they'll take another little bit of blood vessel and then like tie it up on one end and route it around the clog and put it somewhere else and put the blood in. That way you can make sure that you're having blood go to them. My paternal grandfather had total 11 bypasses by the time he passed when he was like 80, 82. He was in the military, so it was free. I actually don't remember how many. There were a bunch. Like there were various times, like just like, oh no, he's going in to have another stent done. Like, cool. Granted, I was in like high school or even middle school, so it was less of a big, like I didn't understand as much. Women can have different SNS of MI. Yes, women can have some different symptoms of their myocardial infarct. So you may see this in slightly different ways in some women. Once again, we live in a patriarchal society anyway, so that's where a lot of the stuff is coming from, is from male perspectives, unfortunately. But that is something to keep in mind, is that where they refer the pain may be a little different, but they will still have excruciating chest pain when it happens. But women can still have them as well, which is also important. There are lots of health problems that can lead into increased likelihoods of myocardial infarcts or strokes and things like that. So it is important that we are aware of those things and you get that kind of stuff checked out, especially if you are like me and have a family history of it. Which is also why me, at being like a reasonably healthy 35-year-old, I'm on blood pressure meds, and I have been for 5 years now, just simply to try and avoid those types of issues. My dad actually went into the hospital one time with a measured blood pressure of 240 over 165. He drove there. That was great. He like blacked out on the way to work one day. He's like, well, I guess I'll go ahead and pull over here. Like, I guess I'll go like turn around and go to the hospital instead, because this hurts a lot, after he like blacked out for a couple minutes. Yeah, it was bad. That's why I'm on blood pressure though, so I can avoid that. Instead, I'll just have cancer. You'll be fine. All right, so once again, we have our cardiac muscle. Cardiac muscle, being cardiac muscle, is very, very important to make sure that the heart functions correctly. That's because cardiac muscle can be autorhythmic, okay? When you tell one piece of the heart to contract, the rest of the heart will contract in the proper order without much help, okay? The nervous innervation to it in a lot of ways is actually to make sure that it slows it down and it does it a little bit differently than the muscles themselves can do it, all on their own accord. Okay, but that's because they are all interconnected in that little network, because these muscles branch and things like that. But we can send signals to multiple muscle cells through our desmosomes and gap junctions in our intercalated discs of the cardiac muscle cells. Okay, so the outsides of the cells are actually all interconnected, so we can continue sending that propagating that contraction signal down the length of the cells. Okay. So the fact that they are all interconnected is very important. Now, you would imagine, or you could probably imagine, that something that is going to be beating on average 60 beats a minute is going to have a fairly high demand, Okay, like I'm not doing 60 push-ups in a minute, ever. Okay. These are going to have a hell of a lot of energy demand to them. That's why they have their own little system of blood vessels going right there. Okay, so we can keep this nice constant supply. We also constant supply of blood, as well as we have lots of mitochondria here to make sure that we are never going into anoxic conditions in our heart ever. If it happens in your leg muscles that you run out of oxygen, that's fine. You can deal with that for a short period of time. You cannot deal with that in your heart. Okay, so we always have oxygen going to it. So we are only ever dealing with aerobic metabolism here, or at least we try. Okay. Now, in order to get signals to the heart, we have what we call our own conduction system. Now, the conduction system is going to start right here with our SA node. So seno meaning high, atrial meaning up, or atria. Okay. So senoatrial node is going to be at the top of which ventricle is this? The right ventricle. Okay. So it's going to be found on the top side of our right ventricle. Now, this is going to send out a signal. And it's going to send out a signal actually. Let's see, hold on. About like this. So this is around 75 beats a minute. Okay. That's how fast it wants to tell your heart to beat. And that signal is coming here from your senoatrial node. Does that seem fast? It is a little bit. That's faster than your heart actually beats. Most of the time, our resting heart rates are around 60. Okay. 60, maybe 80. Okay. Now, yes. Usually you tend to have people that are way above it or way below it. But that's what, yes, you rarely see that particular rate. Okay. That's because our body is actually trying to regulate down. Okay. This is what the pacemaker node would do on its own accord. That is actually what makes the senoatrial node interesting, because this is your heart's pacemaker. Without innervation from the brain to tell it to do something different, that is the pace that it would set. Okay, so this one then will send out a little signal that says, bam, this is when you need to beat. And it's going to send the signal out through our atria. So whenever the SA node sends out a signal, it's going to send out a signal to all of the muscles and all of the atria of the heart to push the blood out of the top of the heart and push it into the ventricles. So this basically says contract so that we can squeeze out all the blood that may be hanging out in the atria and make sure that we have all the blood that we need in the ventricles. Make sure the ventricles are filled is always our priority here. And that's what this SA node is going to be doing. Now, as that happens, as that signal gets propagated down through all the muscles of your atria, it will then run into your atrioventricular node. Okay. Now, the atrioventricular node is going to be found, well, in between your atria and your ventricles. That's atrioventricular. Y'all should be seeing a theme. We've seen that word several times now. Okay. Now, the atrioventricular node will then send a signal out. And instead of sending a signal out directly to the muscles, instead it's going to go pass through this little bundle right here, the atrioventricular bundle. Anyone want to guess what this bundle is also called? People that have worked in the medical field at all have likely heard this. This is the bundle of His. Okay, so if anyone ever says the bundle of His, this is what we're looking for. So, where'd it go? There it is. So here's our bundle of His. Now that bundle of His is going to split into bundle branches. So into the left and right bundle branches, and then we're going to wrap around the apex of the heart. After they wrap around the apex of the heart, we're going to start to have branches out here. These little branches off of the bundle branches, we're going to call Purkinje fibers. The Purkinje fibers are where we're actually going to be innervating the muscle. Okay, bundle branches, we're not innervating the muscle. Bundle of His or atrioventricular bundle, we're not innervating the muscle. We kind of start this contraction at the apex of the heart and then push up. You can think about this as like squeezing all of the toothpaste out of a toothpaste tube. You don't just like squeeze in the middle and expect to get it all out, right? Because what's going to happen if you just squeeze in the middle? Some of it gets stuck in the bottom, right? So if we start our contraction here in the center of the ventricles, some of the blood is going to have a hard time passing through that narrowed region. So instead, we start this process at the apex of the heart and push out. Okay, so we're going to start at the apex and then have the signal propagate up and basically squeeze all of them. Honestly, it happens basically so close together that it's essentially at the same time. But we especially don't want to start the process higher up than it happens at the bottom. We want to make sure that we squeeze it at the very least at the same exact time, but preferably even slightly at the bottom first. Basically, like I said, so we can make sure we can squeeze out all of the blood that we possibly can. Okay, so SA node is the pacemaker node. So sinoatrial node in the top of the atria. Atrioventricular, also found in the right atria, but at the space between your atrium and your ventricles. Going down through atrioventricular bundle, right and left bundle branches, and then finally into the Purkinje fibers. Now, importantly here, we can regulate this. This is more physiology stuff than it is anatomy, but we do have regulation here. So we can down-regulate using our parasympathetic, or we can use our fight or flight response to upregulate that rate. So say you get stressed, you go for a run or something scares you and you need to run like hell, okay? Or get into a fight, your heart rate increases, okay? So we have to be able to upregulate these processes as well. So we can see the nerves that are used and kind of where those nerves are going. But down regulation is especially gonna be common here at our sinoatrial node. So we can down regulate, making sure we can stay at that kind of nice 60 level, rather than the 75 to 100, which is what your SA node wants to do, using your parasympathetic innervation. So your brain basically tells you to slow down and keep everything nice and slow. Now we do this because we have specialized cells in these regions. So your SA node has these special little nodal cells, and these are going to be able to propagate their signals or send their signals out a little differently, okay? That's because some of our little sodium potassium channels in here are kind of leaky. These are basically slowly gated channels. So basically after a contraction, these things slowly open up and allow the rate to, or allow the voltage to slowly change until you hit the threshold, which is our negative 40 millivolts, at which point it sends a signal that says, okay, it's time to contract. So that you basically get this slow buildup of charge and then bam, it'll contract. Slow buildup of charge just as we're relying on diffusion and then bam. Okay, and it'll do it again all on its own. So this is our autorhythmicity. So its ability to maintain a pace, okay? And it's all because we have these little slow channels here that just kind of open on their own. So instead of it being this perfect little ups and downs, you see these little lags as you get this kind of slow buildup. So what your parasympathetic nervous system does is basically try and keep these things closed a little bit so that then it will kind of slow it down to the rate that we need it to be. So we can slow down so the potential is delayed ordinarily to make sure that we have enough time, okay? Now, I'll also add that with your, I keep saying around 60 is what a typical person will have as like a healthy individual. It is actually fairly common for people that are athletes or people with really healthier cardiovascular systems, people that do a lot of cardio, people that do a lot of running and stuff like that, especially athletes. This number tends to be a lot on the lower side, and sometimes even in the 40s. Like it's kind of crazy how low theirs will be, but that's just because their heart gets really efficient at moving these things. Trying to think if there's much anatomy left in here. No. All right. So we will look at the electrocardiograms in just a little bit. I want to give y'all a little while to look at the heart. So on your tables, you're going to see some heart models. So on these heart models, you need to be able to identify everything on that structure list. So remember, the structure list is in the lab instructions portion of the Blackboard folder. So let's make sure we can find all of those parts and pieces. I want to give y'all a little while to do that before we actually start talking about the ECGs. Probably should have done that even before talking about all the SA node stuff. But that stuff is fun. Oh my goodness. Oh, there we go. Go back.